Welcome to the People's Health Briefing, a component of the Trusted Voices campaign. I'm Dr. Novavax from Roots Community Health Center, reporting for the week of October 18th, 2022. Today, I'll be talking about some of the newly recognized Omicron subvariants, as well as the prospects for a fall or winter wave. And I'll give a brief MPX update as well. As health professionals rooted in Oakland, serving some of the people most vulnerable to getting and suffering from COVID-19, we're here to cut through the noise to give you information you can use to make choices that will keep you, your loved ones, and your community as safe as possible. The goal of the People's Health Briefing is to empower you with our best knowledge and thinking every Tuesday morning. In Alameda County, right now there is some sort of a delay going on in terms of the cases coming from the state file to update the cases and deaths. But this data is as of October 10th, and you can see that cases are still kind of creeping down. We're still over 2,000 cases on the 14-day totals. So just coming down ever so slightly, but definitely going in the right direction. If we take a look at the CDC's community transmission map, though, you can see here a little dark red county there is Alameda County. So we've got, or is it dark orange? But it's the substantial transmission. So we've still got substantial community transmission if we go off of the indicators around new cases. Still have a 4.6% positivity rate on our testing, and we know that the majority of people are testing at home, so this is all still undercounting. But we look at the hospitalization data, and although we still have fairly low numbers, 70 in the hospital, 12 of those in the ICU, it is upticking just a bit. We had gotten down to 53 in the hospital and 4 of those in the ICU at the beginning of this month, and so not sure if this is a blip or if we are heading in the wrong direction, but we'll certainly be keeping an eye on that. And when we look nationwide, we're still at 345 deaths per day. This is a bit of an improvement. We were, hovering there in the 400s and 500s for quite some time. Hopefully this trend will continue for a little while before we anticipate cases going back up, which I'll be talking about in a moment. When we look at the variant proportions, this has changed quite a bit from when I reported 2 weeks ago. And so you can see we've got a whole bunch of new colors here that have made it onto the chart. And so most notably is sort of that olive green, and then I guess there's sort of like a darker green there further out to the right. And what those two represent are BQ1 and BQ.1.1. And those were not even on the chart any previous time that I've actually reported. And so it's a little concerning that not only have they made it on the chart for this past week, but also for several weeks before that. And so this tracker always sort of gets updated and they go back and update prior weeks. So it's sort of unclear why this is just now making it on here. And I'll get into a little bit of why this is, a little concerning. But if we take the BQ1 and the BQ.1.1 together, we're looking at 11.4% of cases all of a sudden being taken up by these BQ1 and 1.1. And the BA5, which when I reported 2 weeks ago was 81% of our cases, is now down to 67.9%. So it appears that BA5 is being displaced to some extent by these BQ1 and BQ.1.1. The second in place after the BA5 is the BA4.6, and that's kind of staying around the 12%. So the concern is that this BQ1 and the BQ.1.1 are already, they're already in place number 3 They may soon make it to number 2. And we've still got the BA.2.75 in the maroon there. It's kind of staying around the same, about 1.5%. And the BF7, which is the lighter olive green, is now at 5.3%. So some movement here in these variants. I think the bottom line is that we've got this BQ1 and BQ.1.1, which are they're doubling at a concerning rate, and they are appearing to displace the BA.5. So I'm going to talk a little bit more about what all this means in a little bit. But first, let me do a quick MPX update. Monkeypox cases. So we're no longer sort of seeing this exponential growth, which is great, but we still are having growth. So we still are seeing increases of cases. Worldwide, when I reported 2 weeks ago, we were at 68,428 cases. We're now at 73,288. In the United States, we went from 25,851 cases to now 27,317 cases. State of California was at 5,010 2 weeks ago, now at 5,278. And Alameda County is at 232 cases now from 221 a couple weeks ago. And so you can see here on the cumulative cases in the state of California, we're at 5,278 cases that have been identified so far. And so it's definitely smoothed out. We're not on that rapidly increasing trajectory. So that certainly is reassuring. At this point, what we really, I think, want to do is ensure that anyone who may be at risk should get vaccinated. And anyone who gets the rash, a new rash, should have it checked out, because we don't want this to be getting transmitted and spread any further. And so what I think we're looking forward to now is hopefully a recommendation that healthcare workers can be vaccinated. At this point, it's really just being reserved for folks that are engaging in behaviors that may put them at greater risk of catching MPX in the community and in their, in their day-to-day life. But it is also an occupational exposure. And so to the extent that we have enough vaccine supply, hopefully that will come next. So we're just kind of waiting to see what the recommendations will be around that. But at this time, what we're really looking at is that we still have cases that are happening, and we want to make sure that we are testing, getting them diagnosed, getting folks treated, and getting people and their contacts vaccinated. So this is definitely, I think we're feeling pretty good about the way things are going in the overall sense in terms of it not becoming a global pandemic. So that's good news, because we already have one that we're dealing with. But nonetheless, I think for folks that are at risk, we want to make sure that they have the information, that doctors are asking the right questions, and that we are vaccinating anyone where we can make an impact and prevent getting this very uncomfortable, painful, and contagious virus. And so now, kind of going back a little bit to these new variants and whether this means, or whether we think we'll be looking at a fall or winter surge, and kind of what we're looking at. And things have changed a lot over the last couple of years in terms of how we're even looking at numbers of cases and waves all over the world, and what that's going to mean for here. We know that right now the UK is seeing an uptick of cases, and historically we've kind of followed by about a month or so. So we certainly still keep looking at that. But now I think we have a little bit more nuance about the different variants that are happening and where they're cropping up and what we're concerned about. It sometimes doesn't feel fast enough, but we do have more information, I would say, in that regard, and hopefully, ideally, more lead time to be able to prepare. So I talked about the BQ1 and the BQ.1.1, and it appears that in the UK and also in Denmark and Belgium. They're all seeming to have this BQ.1.1. It seems to also be picking up some steam in New York. And so we know that all those places kind of have been the early indicators before we start seeing spread across the country. But we've also seen that now we've just got these kind of local areas where one variant seems to be taking over more than another. And this creates different types of competition in different areas between the variants. So we can't say for sure if this means that BQ.1.1 is going to come here and take over. But as I mentioned, we are concerned with the fast doubling time of the BQ.1 and the BQ.1.1. And part of the concern about it is that it's spreading quickly and it is evading some of our prior immunity. And specifically, what's a big concern is that it is evading both the Evusheld, which is the medication, the monoclonal antibody that we give to folks who are immune compromised and might not mount a good response to the vaccine. And that's to give them 6 months of protection so before they catch COVID, or to prevent them from catching COVID or getting sick with COVID. And that has been really effective up until now. But with some of these new variants, it's not so effective. So actually the not only the BQ.1.1, but also the BA.4.6 and the BA.2.75.2, which I mentioned earlier, those all are looking like they're evading Evusheld. So this is a problem for all of the people that have been relying on it. And although right now, again, 70% of what we're dealing with is BA.5 and Evusheld's doing great against BA.5, we're having this creeping in of variants where folks who are relying on Evusheld for protection may not be able to rely on it so much. So we're certainly hopeful that we'll get some new monoclonal antibodies on the scene, but more and more of what we're reading and hearing is that because the amount of funding being allocated by our government is not there just isn't a guaranteed customer, so to speak, to purchase all of these new wonderful monoclonals that we want to be developed. If they don't have a customer, they're not going to be developed. And that's just how it works here. So I think this is part of what's concerning, is that as time goes on, we're going to have to stay in reality about whether this Evusheld is going to be holding up against the variants that are coming. And of course, this is concerning about where we're heading with the BQ.1s taking up already, over 11% of the cases in such a short time. So we'll just have to keep on watching that and keep on communicating about it, because the other thing that BQ.1.1 evades is the bebtelovimab, which, if you'll remember, is our one of our top choices for treatment for folks who catch COVID-19. And so there was a study last month from Peking University's Biomedical Pioneering Innovation Center in China. And this is what was giving us some of this early data about the BQ.1.1 evading both the Evusheld as well as the bebtelovimab. And so quickly on treatment, the bebtelovimab, we like it because it is a one-time infusion treatment. It's suitable for people 12 and up, and you can do it within 7 days of catching SARS-CoV-2. And it is a perfectly respectable treatment, reducing hospitalization and death somewhere in the 80% range. And so we don't want to see that option sort of wiped out. Our top choice, our first line treatment, by far pretty much, is Paxlovid, because of a couple of reasons. One, it's very, very effective. It's an oral medication for 5 days, also suitable for 12 and up, but you do have to start it early within the first 5 days. And our second line treatment, remdesivir, super important. It is an IV treatment, but it's super important because we can give this to all ages, all the way down to the newborn. And we know that our little ones under 6 months of age aren't even eligible for the vaccine. So it's really important that we know that for those little high risk, the little ones who are high risk, that we do have a treatment, remdesivir. Right now, the monoclonals are still working, But if things keep on moving in this direction with the BQ.1.1, then we are going to have to reconsider that. And what we saw happen last year with Omicron is that once the Omicron kind of came on the scene, and it did so too quickly, basically all of the monoclonals we had at that time, we had to stop using them. And it happened at a really critical time where we were in the middle of a surge, realizing we couldn't use one of the tools that we had. So I'm really hopeful that this time around we'll be smarter about it and quicker about it, about realizing that maybe the bebtelovimab won't be working, or we'll be keeping tabs on it, or even better, hopefully we'll have a replacement for it, because the monoclonal antibody treatment is still a good option for a lot of people who may have some kind of reason why they cannot take the Paxlovid, which could include like severe kidney disease or certain medications. But let's keep in mind that most medications can just be paused during the Paxlovid treatment. So please do not be discouraged, and please really advocate for yourself, because we're still hearing really wild things coming from people's primary care doctors about why they won't give the Paxlovid when it really is saving lives. And I really think that a lot of the lives that we're losing right now, we could be saving with the Paxlovid. And then that molnupiravir, really, it is really of questionable utility here. And so the molnupiravir is sort of, it's about maybe 30% effective at preventing hospitalization. So with these other options that are in the 80s, there's just really very slim indications for that last one there. So that was just a quick review on the treatments, but I think it's pertinent because I think we need to, first of all, I think we need to be reassured that Paxlovid and remdesivir, because of the way in which they work, we don't anticipate any issues with them not working against these new subvariants. So that's very good news. I want to reiterate. It's really the monoclonal antibodies that are really specific. They're antibodies. They're basically giving us what we call passive immunity. And so they really do have to be tuned to the variants that we're dealing with. And so it is unfortunate news that the BQ.1.1 is picking up steam and is evading our monoclonal. So we will continue to report on what that is looking like. And so what is sort of the risk that we're dealing with? Well, I came across this Ontario risk assessment that I really like, where they do a much more detailed job than what I'm seeing here from the CDC on a risk assessment for the different subvariants. And so this is a really simple table that I cut, but I put the link in the post in case this is of interest, because I like how it takes the subvariant and it breaks down all the things we need to look at. Is it more contagious? Yes, it is. Is there a potential for increased disease severity? Well, we're not really sure yet. But can it get around our therapeutics? Can it cause reinfection? And can it get around our vaccines? And so this is really important. And right now, the way that the CDC appears to be approaching it is lumping still all the Omicron subvariants. So all that alphabet soup that I just named is all just kind of being lumped into variants of concern as Omicron subvariants. And there's actually some experts that feel like this BQ1, really needs its own Greek alphabet letter at this point, because it is quite different from the original Omicron. And these different variants are offshooting from different lineages of even the Omicron. So the stuff starts to get a little tricky to keep track of, and there's really not a specific reason to keep, I think, to worry too much about one thing over the other than how I explained earlier. If it's going to get around a treatment and it's something we're relying on, we absolutely need to know about that. So this is just one way of kind of looking at it. And I'm sort of hopeful that we're going to get a little more sophisticated around here with these variants, because the state of California is basically just also lumping everything together as Omicron. CDC is kind of essentially doing the same as it relates to trying to look at the different severity of the different sublineages. And that's just not really going to cut it. We've got this wastewater infrastructure. We need to be sequencing that so we know what's coming and we know how to best address it. The other new variant that we're concerned about is called XBB. These names. And so XBB is really taking hold in a couple of other parts of the world, Singapore being one of them. They're having sort of a sharp spike right now, and their health leaders are saying that they expect it to peak sometime in early November and then come back down. But the red color there is the XBB variant. So you can kind of see how it's displacing the other ones. And XBB also turns out to be of concern for similar reasons of it getting around our monoclonal antibodies. And we're a little bit concerned about, reduced effectiveness of some of our vaccines. But so far, and it's going to take time before we really know, how well the vaccines are going to hold up against all these new variants, because we just have like a changing landscape while we're trying to keep up with everything. But it remains the best chance that we have, and it does provoke a good enough antibody response to sort of a diversity of both the old wild type of SARS-CoV-2 as well as the BA.4 and 5. So since we're getting really close to all the relatives of these new ones that I'm mentioning, it's definitely the best tool that we have at this point in time to protect us against these emerging variants. I wanted to mention that when I started digging around on Singapore's dashboard, because of hearing about the XBB and the fact that the XBB seems to be making its way here to the United States, 79% of their eligible population is boosted. So that's pretty impressive. But nonetheless, they're seeing this spike and they're seeing an increase in hospitalizations as well. So no evidence that XBB is more severe per se, but it is causing reinfections, it is causing hospitalizations, and this is in the setting of a population that is highly vaccinated. 79% of their total population is boosted. And that's by contrast, here in the United States, only 39% of our over 50-year-old population is boosted. So that's pretty low percentage. We're going to need to get that up, because in order to answer this question, are we going to have a peak in the fall or the winter? I think it depends very heavily on how well we do with our boosters, because if we aren't doing the boosting, then what's happening on a population level is that we've got waning immunity sort of across the board. We've got a lot of people who have not been vaccinated at all in a year. And they are essentially, they don't have any specific protection against the BA.4s and 5s, so that's an issue. But even the protection that they do have is wearing off because it's been so long since they've gotten the vaccine. And, when I look at the vaccination rates overall in the United States, we still only have 68% that have finished the primary series. So that leaves 32% of our population that's really, under vaccinated. About 20% haven't had any vaccine. And so this unvaccinated population still remains the most vulnerable to a bad outcome, but certainly under vaccinated do as well. And we are still seeing deaths among people who are especially older and who are not boosted. So I'm not sure why we're having such a lackluster response to this particular booster campaign. It's definitely not as prominent of a campaign as some of the past ones. Not a lot of people are really availing themselves, but we do have over 25 million people who have received it. So that 39% I mentioned, it's 25,600,000 some people who've received it. And that's a really good high number if anyone was sort of waiting. I know that we've had that a lot throughout this pandemic. Well, I want to wait. I don't want to be the first one to get it. I want to wait for more people to get it. So I think now is a perfectly reasonable time to do that after over 25 million doses of this booster, as well as all the track record and history that we have so far. I think we can feel very comfortable. And then by way of a reminder, if you're just not comfortable with the mRNA for some reason, you rather go a different route, please consider the Novavax vaccine. That also is not being promoted at all. I'm finding that very few people know about it. A lot of people are asking about it as a booster because they want to do something different. But unfortunately, it's still not approved as a booster yet. That's something that we are anticipating. We just don't know when that's going to happen. It's probably not helping that it's off to such a slow start. But I really hope that we'll all continue to kind of get the word out, because Novavax uses an older technology that some folks may be more comfortable with. It's an adjuvant vaccine, and that is the same type of vaccine that we use for like the flu and hepatitis and many other vaccines. It's an old technology, and it does have some pretty promising data behind how effective it is. And so even though now at this point it's pretty much impossible to do any kind of head-to-head comparison like we had the early days of the pandemic, we can't do that anymore because there's too many combinations of situations out here. But nonetheless, Novavax looks to be providing a really robust response. And so if you know anyone who's still unvaccinated and they said it was because mRNA is too new or came out too quick, please give them the good news. They can now get the Novavax shots, and it's 2 injections, ideally about 8 weeks apart. And by way of updates on the vaccine boosters, just wanted to make sure that everyone knows that the bivalent booster, which is otherwise known as the Omicron booster, is now approved down to 5 years of age. So 5 and up, if it has been 2 or more months since your primary vaccination series or your last booster, or even from catching COVID, then 5 years and older eligible for the bivalent boosters, and that would be either Pfizer or Moderna. Also want to make sure everyone knew that the Novavax is approved down to 12 years old. And so again, that is for a primary series at this point in time. And so when we sort of take into account the surging that appears to be happening in Europe, the fact that there are some concerning variants in other parts of the world that are causing spikes, like the XBB that is making its way over here. We don't know what that's going to do here. Is that going to outcompete some of the ones we have, or is it not? Difficult to predict. But I think that, you know, everyone pretty much agrees and recognizes that as we head into the colder weather, as we also head into the holiday season where folks begin to mix and travel more, there will be increases in cases. In fact, I wanted to point out that in Milwaukee, because they hit the medium COVID-19 community level, they reinstated their mask mandates on their bus system. And there's been talk in other parts of the world, like Germany and other countries, about when and if they would reinstate masks in some settings. And so I think that we should just recognize that, you know, that cases will begin to go back up again. We are vulnerable here in the United States for the simple fact that we are not very well boosted at this point in time. And we don't have mitigations in place like many other countries still do. And so we see countries that have done phenomenally well, like Japan, who kind of have maintained masking and who do things like cohorting in the schools, the things that we have just failed to do here or refused to do, or whatever the case may be. We're seeing slowly starting to see some movement around improvement in ventilation and some attention being paid to that. But by and large, most people are kind of wanting to behave as though we're not in a pandemic. And I think the defining reason why we are still in a pandemic, despite maybe we don't want to be, but is because we are still in an unpredictable situation where we really do not know when, you know, how bad it will get. We know that we will see more cases in the winter, but will we fill up our hospitals? I think that that is definitely a concern. Part of the concern is not only because of COVID, but it's because we do anticipate having sort of a normal, a pre-COVID type of a flu season. And so I think I think we've heard a lot of, getting worried about being infected with both at the same time. I'm sure that it can happen. I don't think we've seen that really come to fruition, thank goodness, so far. And I think that's less of the worry. I think the bigger worry is that if we have a regular flu season and we have a winter COVID surge that we sort of do anticipate, can we overwhelm our hospitals because we're dealing with both? And this is not to mention some of the increases that we know we are seeing with post-COVID strokes, heart attacks, and other events that take people to the hospital. So I think that we should still be very vigilant in terms of thinking about our healthcare system capacity to handle what is coming in the winter. I think that when we look at some of the modeling that's out there, there's definitely some models that are suggesting that depending on, again, how these different variants play with each other, that we will be seeing sort of increasing cases, late November, December, in that time frame. But most of our models don't go very far out. And so we're constantly sort of looking just a few weeks out. My hope is that we're going to get better about communicating what the modeling is looking like. We'll get better at communicating what our community levels are and whether that should be a trigger to do something like what Milwaukee did and reinstitute masks in certain environments in order to reduce the spread and to reduce the likelihood of an overwhelming surge in which we lose lives. I think that even though, I'm certainly concerned, I'm going to be watching these variants, and I don't like the fact that some of our tools may become obsolete. The tools that we do have are excellent, and we need to be using them. And I think even for folks who are unvaccinated or undervaccinated, the key for them is going to be using those tools of testing early and getting treated. And testing early, I think, is something that we're seeing fall away a bit. And I wanted to point out that what we are hearing and seeing with some of these variants that are becoming more prominent is that some folks are getting predominantly GI symptoms, particularly early on. So I wanted to make that point that if you're having, gastrointestinal symptoms, diarrhea, nausea, vomiting, don't just write it off as food poisoning. This would actually be an indication that it's time to do a COVID test. And so you can certainly do a home test, but if you're pretty suspicious and if you're someone who really needs to get treated if you catch it, think about going to get a PCR test. We still have multiple places throughout the county, including at Roots, that are still doing the PCR testing. And the good thing about the PCR testing, there's a few good things. One is it turns positive much sooner than the home test. So you will keep yourself from spreading it to other people. You will be able to get treated more promptly. And you'll also have documented proof that you had SARS-CoV-2, which we are certainly hearing that for people who are experiencing long COVID, people who are becoming disabled because of long COVID, that actually having documented proof is turning out to be something that is important because you may need to demonstrate that you indeed had SARS-CoV-2 in order to, unfortunately, prove that your symptoms could be from long COVID or post-COVID. And so I think the bottom line is we do anticipate a surge in the wintertime. Hard to predict which variants it's going to be primarily driven by, but that's going to be important because that's going to dictate what's in our armamentarium of tools that we can use against SARS-CoV-2. So it's going to be important to keep track of that. I think because of that, I think it's really important that particularly if you are 50 and up, or you have any conditions that put you in a higher risk category, that you go ahead and get that Omicron booster or the bivalent booster this month, ideally. And certainly at least 2 weeks before you are going to travel, go into any high risk settings, visit any high risk people. Don't wait. We've been hearing this literally for the last couple of weeks. We've been having cases crop up that have been saying, "Ooh, I was just about to get my booster, but I waited too long. So just don't be that person. Go ahead and get that Omicron booster, ideally in the month of October. And also that flu shot, ideally also sort of, by early mid-November. And we'll be keeping an eye on, the flu to see how, when it's starting to pick up. But so far, it looks like the flu vaccine that we've selected for this year is well matched to the flu strain that are circulating. And if you think you're a person who's not going to show up twice for a vaccine, just go ahead and get them both on the same day. You may experience some side effects, symptoms, feel like, you got a little bit sick, a little mini version of the flu, but that's definitely better than catching the flu and it's better than catching COVID. But if you're someone who can be pretty reliable about these things, you may want to space them a few weeks apart because you get a little bit of a bump in some of our more general immune cells like natural killer cells and so on that are going to help against everything. And so spacing out is not a bad idea, but let's get it all done like in the next few weeks, so that by the time we get into the holiday season, you are very well protected. And let's not forget about our little ones. We've lost over 1,500 children to SARS-CoV-2. We have launched major vaccination campaigns for far, far less. Some of the things that we've vaccinated against only, I don't want to say only because we never want to lose a child, especially to a vaccine preventable illness. But this one has claimed a lot of little lives. And so there's really no reason why we would want to avoid vaccinating. This is a vaccine preventable illness, vaccine preventable hospitalization, vaccine preventable death, and that includes our children. And let's not forget, when we start to gather around for the holidays, especially, you've got little ones gathering with grandma and great grandma, and we do not want to see any more loss from SARS-CoV-2, and we don't want to see any more families devastated by that type of transmission that I'm mentioning. And the best way to guard against that is to have the family vaccinated. And of course, we are going to do all of our usual mitigations, avoid going into indoor crowded spaces, but if you need to, wear a high quality filtration mask like N95 or a KN95. And we're going to still try to gather outdoors when you can. We've got some great restaurants throughout the Bay Area that have outdoor seating, and maybe you've got the heater so you can be comfortable outside. It's still the safest way to gather. And definitely, if you have any symptoms or you think you were exposed, please get tested as promptly as possible and get treated if you're eligible. And know if you're eligible ahead of time. Please don't wait till you're sick. It's the worst time to be scrambling around and frankly arguing with folks about trying to get treatment that you are entitled to. Because unfortunately, that is what's happening a little bit too often. And so go ahead and have that conversation with your doctor now and make sure that you are going to get what is appropriate for you, which for majority of people is going to be the Paxlovid. And if it's not, you want a really good answer as to why, and trust but verify. There's nothing wrong with asking for a second or third opinion. And until COVID really becomes part of the day-to-day work of our primary care doctors, unfortunately, that's something that we may need to do, because pretty soon that's the only place we're going to be able to get any kind of COVID services. And I think we're all going to have to ensure that there is some level of accountability there. And so that's up to, unfortunately, kind of each and every one of us. So in the meantime, please continue to be good to yourself, be safe out there. Get a good night's sleep, consider a multivitamin with additional vitamin D supplementation, get some exercise, eat a well-balanced diet, and manage your stress. And if you have any feedback, questions, comments, please email them to admin@rootsclinic.org. Thank you so much for joining us, and we'll see you again next Tuesday at 10 a.m. See you then.